Welcome back, everyone, to part 61 of our 100-part ICD-10-CM Guideline Explainer series. I'm Harshal, and today we're continuing our deep dive into Chapter 19, Injury, Poisoning, and External Causes. Our mission right now, completely mastering section IC19D. We're going to decode the strict rules separating thermal burns from chemical corrosions, unpack those unbreakable depth hierarchy laws, calculate total body surface area using the rule of nines, and tackle some tricky non-healing burn exceptions. There's a lot of high-stakes coding logic here that directly impacts trauma center reimbursement, so let's get right into it.
Okay, here's our quick roadmap for today. We'll hit burns versus corrosions, the depth hierarchy law, the rule of nines, non-healing and infected burns, and wrap up with chemical corrosions.
Starting off with Section 1, Burns versus Corrosions.
Now, it's really interesting how ICD-10 strictly categorizes these injuries. In everyday conversation, you'll hear people say someone suffered a chemical burn, right? Well, in medical coding, that phrase literally doesn't exist. A burn, which you'll find in categories T20 through T25, specifically refers to thermal injuries. We're talking heat sources like a fire, a hot appliance, boiling water, plus electricity and radiation. On the flip side, if that tissue damage is caused by a chemical, an acid, or an alkali, you must use the corrosion categories, and those are T26 through T28. Once you've established whether you're dealing with a burn or a corrosion, you have to classify it by depth. First degree involves erythema. That's just superficial redness of the epidermis. Second degree goes deeper into the dermis, causing blistering and epidermal loss. And third degree is the absolute most severe, involving deep necroses of the underlying tissue or full tissue skin loss. But quick heads up, burns of the eye and internal organs are an exception. Those are actually classified by site, not by degree. Let's jump right into Section 2, the depth hierarchy law. Here is a golden CMS guideline you absolutely need to memorize. Sequence first the code that reflects the highest degree of burn when more than one burn is present. Basically, the absolute highest degree of severity is always going to dictate the sequencing order on your claim form. Why? Because if a patient comes in with multiple burns, the highest resource utilization is always going to be focused on treating the most severe tissue damage.
So if we're building out a claim for a patient who has a third-degree burn on their chest, a second-degree burn on their thigh, and a first-degree burn on their arm, that third-degree chest burn completely knocks the lesser degrees down the list. It takes slot number 1. It absolutely does not matter which body part was injured first in the accident or which area is higher up on the body. Highest degree always leads. Oh, and if you have different degrees of burns at the exact same anatomical site, you only assign a single code for the highest degree at that specific site. But what happens if you hit a tie? Say the patient has third-degree burns on both their arm and their back. The guideline gives us a super simple tiebreaker. If multiple burns share that exact same highest degree, you just sequence the code for the anatomical site with the greatest surface area first. Since the back has a way larger surface area than the arm, the back takes the primary slot. Which perfectly sets us up for Section 3, the rule of nines and total body surface area, or TBSA.
The classic rule of nines is the clinical standard we use to estimate the extent of the body surface involved. It breaks down like this. The head and neck are 9%, each arm is 9%, so 18 total for both. The trunk is 36%, that's 18 for the front and 18 for the back. Each leg is 18%, making 36 total for both legs, and the genitalia accounts for 1%. Now, providers might adjust these numbers slightly for infants using the Lund-Browder chart, but the rule of nines is your standard baseline for calculating your T31 burn and T32 corrosion codes.
Once you've got those percentages from the provider's documentation, building your T31 or T32 code is a two-step process. Step 1. The fourth character of the code reports the total surface area involved across all degrees of burns combined. Step 2, the fifth character specifies only the severe third-degree area. This dual-axis reporting is fantastic because it tells public health officials and hospital admins exactly how much of the patient's body was impacted and what specific fraction of that was life-threatening full-thickness necrosis. And remember, this secondary code stacking is absolutely mandatory in certain situations. It's highly advisable anytime a burn involves 20% or more of the body surface. This specific data dictates severity validation for burn ICUs, it evaluates mortality risks, and it justifies the heavy diagnosis-related group weight required for trauma center transfers. You always code the specific burn sites first, then stack T31 or T32 to paint the total picture.
Moving into Section 4. Non-healing and infected burns.
Okay, here's a rule that catches a lot of coders off guard. Non-healing burns are coded as acute burns. Sometimes you'll see a patient coming back weeks later with a burn that simply isn't closing up, and the instinct is to use a sequela code because time has passed. The guidelines explicitly say no. If it's actively non-healing or if there is necrosis of the burned skin, it is still categorized as a current acute injury. You have to keep using the active treatment seventh character, like A for initial or D for subsequent. No S for sequela here.
Now, what if that burn gets infected? When a burn is infected, you're required to use a mandatory two-step sequence. First, you code the acute burn itself, following all those depth and sequencing rules we just talked about. Second, you follow it up immediately with an additional code to pinpoint the infection. So if it's a staphylococcal infection, you'd pull a secondary code from category B95 to identify that exact bacterial agent.
And finally, Section 5, Chemical Corrosions. For an infected chemical corrosion, the stacking is incredibly meticulous. Let's build a claim. In slot 1, you sequence the highest degree corrosion site, let's say a corrosion of the right forearm. In slot 2, you stack your T32 code to document the total body surface area affected. In slot 3, you drop in the localized infection, like cellulitis. And then in slot 4, you absolutely must report the external cause T code that identifies the exact corrosive acid responsible for the injury.
You can never forget that corrosions, and burns for that matter, require robust external cause coding. You need a T code from the table of drugs and chemicals to identify the specific chemical agent. You need to know the intent. Was this accidental or an assault? You need the place of occurrence, like a factory or someone's garage. And you need the patient's activity at the time of the incident. This is how you paint a completely auditable picture of the encounter.
Now, everything we've covered so far is perfect for acute care and active healing. But you might be wondering, what happens when the patient comes back months or even years later, dealing with the late effects of these injuries? Things like severe scarring or really painful joint contractures.
For these late effects, that's when we finally bring in the seventh character, S for sequela. But here is the real trick. We completely flip the sequence. The guidelines state you must put the specific sequela, like the code for the scar or the contracture, first. Then you follow it with the original burn or corrosion code carrying that S extension. The S code is basically just a historical marker sitting in the second slot to explain why the scar exists in the first place.
And that completely wraps up our breakdown of section IC19.D. You now have the exact tools you need to sequence depths, calculate TBSA, and stack those tricky corrosion claims. But the big question is, are you ready to conquer adverse effects, underdosing, and the high-stakes T-code table matrix in Part 62? Because next time, we're diving deep into what happens when medical treatments go wrong. Thank you so much for joining me for this explainer. If this helped clarify the guidelines for you, make sure to subscribe, hit that like button, and share this with your fellow coders or health information management students. Your support is what keeps this series going. Until next time, keep your codebooks close and your sequencing sharp. I'll see you in Part 62.